and I'm going to hand over to you. Thank you very much.
Thank you, Roz. So I can't see anybody and I can't see the chat, so Roz is just going to help me by kind of putting questions to me if it needs to, but I'm not being rude, I promise. So I am Eleni Baldwin. I'm a consultant geriatrician at Hillingdon. I'm also the clinical specialty lead for elderly medicine at the moment, and I'm also the frailty lead at the moment. There isn't a care of the elderly lead who is interested in palliative care, but I think if there was one, that would be me as well. So this talk kind of suits me really nicely. So I'm going to just start talking about frailty. You know, what is frailty? Why do we care about frailty? A little bit about the backgrounds, the main two different frailty models that we use, how we recognise frailty and what we can do about it. And I think having kind of done this presentation, actually, I don't really even need to do the next bit about why we overlap so much, but I have. There are quite a few slides about why we overlap, but you can see from me just describing what frailty is, about why there is such a big overlap between frailty and palliative care. So what is frailty? So I think this can be quite a barrier to talking about our patients about frailty. And I'll kind of go on to this in a bit. So I'll start with kind of the medical definition of frailty, and it's quite a mouthful. I'm going to read it because it's very lengthy. So it's a distinctive health state related to the aging process in which multiple body systems gradually lose their inbuilt reserves. It's both a risk and a predictor of adverse outcomes, meaning that you have a minor event resulting in dramatic changes. So, you know, that is hugely wordy. And if you're trying to describe frailty to kind of the lay person, and even to kind of your colleagues, that is a really big thing to try and get your head around. So I try and say it's, you know, it's loss of reserves equals poor outcomes, and it's just kind of, that is it in a nutshell: loss of reserves, poor outcomes. But it really is kind of this very minor things that you and I are kind of robust, non-frail individuals would be able to get over without any kind of adverse outcomes. Somebody who's old and living with frailty really can't. So the risks, the kind of the main ones that we talk about are delirium, falls, institutionalization, hospitalization, the dependence, and death. So I think you can see from, you know, slide number whatever 14 that frailty is a risk and also a predictor for death. Is now recognized as a long-term condition. And I'll show you the Department of Health definition of a long-term condition. It's a condition that can't be cured, but it can be controlled. But we do have a real problem with the word frailty. And, you know, if you look up in the Oxford English Dictionary, this is what it says. You know, frailty is an adjective. So, you know, it's a describing word, which is very easy for a describing word to be a label. So it's, you know, of a person weak and delicate, small, frail, vulnerable. So, you know, these are quite derogatory terms if you're trying to talk to a patient about being frail. When I think about kind of my own language, my language to my patients, I never say what you're meant to say. So the kind of politically correct way of phrasing it is that it's, you know, you're phrasing it as a condition. You're not labeling them, but you say that they are living with frailty. So it's living with a medical condition. I have to say I still don't do that, but that's what you're meant to do. And actually, when they've done studies looking at, you know, what do older people think about themselves, even if we think that they are living with frailty, they often don't think that they're living with frailty, and actually they don't like being described as being frail or living with frailty. So this is kind of a different way to try and translate it, you know, using a paper boat analogy. So, you know, sometimes it's helpful for more relatives, I would say, but also maybe colleagues. So this idea that frailty is like a paper boat. And I think the best way that I can talk to you about the paper boat analogy is actually to read you somebody's blog. And it's a doctor called Patricia Campley. She's an elderly medicine consultant, and her blog is just so beautiful, and it's beautifully worded, and it really does demonstrate not only what frailty is, but how it progresses to end of life. So I am actually going to sit and read it to you. It only takes a couple of minutes, but it's worth it. So she says, I've been reading a lot recently about the word frailty and its importance within medicine for older people. We see a lot of frail people, and as geriatricians, they are our core business, both inside and outside the hospital. Healthcare professionals have debated over the last few years how to define frailty and even how we might begin to measure it. It's no longer adequate simply to shrug and say we know it when we see it. From a patient or relative's point of view, however, the word frailty seems to be at best somewhat vague and at worst derogatory and demotivating. When we ask patients how they feel about the word, whether in large surveys or on a one-to-one basis, they do not like it. One strategy that I found useful over the years, especially when talking to relatives, again, she says relatives of the patients under my care, is to paint a picture that they can relate to by using a simple analogy. I'm sure others have used similar techniques. Indeed, I learned this one from a consultant colleague many years ago. So when I'm talking to a family member about their older relative, I sometimes liken their clinical situation to a fragile yet beautiful paper boat sailing round a pond of their choice. A while back, I used this strategy for a very elderly man under our care who was going through a very complex and unstable time. At one point, there seemed to be a lull in the medical winds that were buffeting his fragile frame, and I sat down with his daughter to chat things through. She was desperately seeking reassurance, but also wanting honest facts about what to expect over the months to come. She smiled as I described my image of a beautiful paper boat, brightly painted and currently sailing proudly in the sunshine on the still pond, giving pleasure to all around. I explained that the difficulty was in not knowing what weather was ahead and the problems forecasting accurately. If the weather were to remain fair, with barely a trace of wind, then there was no reason to think that the boat might go down and indeed might sail on for quite a while. If, on the other hand, the wind got up, or worse, if it started to rain, that frail wee boat would go over quite quickly with little we could do to save it. As younger and healthier individuals, we react much more like little tugboats of wood and steel. We would simply bob up and down until the storm had passed, though a big enough hurricane could be too much for us too. The chat developed a bit more as we translated some of this into more medical language and formulated a plan over what would and wouldn't be reasonable things to try should that wee boat capsize over in a high wind. We agreed that we'd want to try as much as we could, maybe including intravenous therapy, but at the end, a call to the family rather than futile attempts at CPR would be the right strategy. I noted it all down and his daughter undertook to update the rest of the family.
Sorry, Eleni, I've accidentally muted you when I was trying to admit someone. Can you unmute again, please? Sorry.
Can you hear me now?
Yes, thank you. Sorry about that.
That's okay. So I don't know where we stopped, but I just got up to the patient's daughter sending Tricia a text. Dearest Tricia, I'm sending this sad message to you to let you know that last night the paper boat went down in a storm. It was all very sudden at the end, but we were well prepared, and for that we thank you. I called the patient's daughter later that afternoon and we chatted about what had happened. I don't think we used the word frail at any point in her father's journey, but she knew what we meant, and I think it did help. It was also lovely to be able to talk afterwards and listen to how the last chapter of the story had unfolded. It's rare as hospital doctors that we get to do this kind of post-bereavement support, and for me, it was well worth being home a little late again that evening. So I think, like I said, I think for all my kind of slides and everything, that really is kind of the crux of frailty and how it overlaps with palliative care, this lack of reserve leading to poor outcomes and into death sometimes. But she writes so beautifully, so I thought I had to share it. Oh, and now my screen's got stuck. Oh, there we go. So coming back to kind of, the nuts and bolts of frailty. So why does frailty matter? Sorry, my screen. Okay, so it's really common. So 10% of people aged 65 have frailty, and that rises to between 25 and 50% of those over 85. I would just say that still leaves 50% of 85-year-olds that are not frail. They're the highest users of services across health and social care, and they've also had the highest levels of unplanned admissions to hospital. This is one of the reasons that we're so focused on frailty at the moment, because we know that our elderly population is going to have a massive boom. So this graph is from 2009. You can see that we're already halfway through this. This is age going up here. I'm hoping you can see my cursor. So this is a 15-year-old and this is an 80-year-old. And you can see as you follow around, there's a small increase in kind of the younger adults, but you have this massive increase when you start looking at the over 65s, with females predicted to go up from 31.42 million to 36.1 million, and males from 30.37 million to 33.51 million. And, you know, the aim really is that it isn't just to live for longer, it's to live for well longer. And the same as that, dying is not just for palliative specialists, it's for everyone, it is everyone's business. This is going to be exactly the same for frailty. It's not just for geriatricians. There are not enough of us, the same as palliative care, there are not enough of us to go around. It has to be that everybody can manage frailty. Sorry, I'm trying to move on. My slides are being a bit slow. Okay, so why do we identify frailty? Again, when I was sitting and reading this slide, it's very similar to why do I identify end-of-life care? Because we want to do what's best for the patient. And if you don't know that somebody is frail, or you don't know if someone's dying, that you're not going to be providing the care that they need. You might be doing things that are actually harmful to them. So the same way as if you've got somebody with very severe frailty or living with very severe frailty, actually you probably don't want to be doing a joint replacement for them, because it would probably give them more harm than good. Again, I really like this slide. It's very simple. So it's meant to be kind of divided into kind of your functional abilities. So this is your being independent and this is being dependent. And there's this line in the middle where you tip over from one to the other. I tend to use it for thinking about lots of things. So it can be somebody's, you know, propensity to fall, somebody's propensity to develop delirium, this idea that an older adult living with frailty is much closer to the line anyway to start with. And actually, whereas you and I would be up here and we have you know, the example here is a urinary tract infection, we feel a bit crappy for a couple of days, but actually we rebound really quickly and we go back to exactly the same level that we were before. Whereas an older adult living with frailty, much closer to this line anyway, you know, a gust of wind, a bit of uneven pavement, a UTI results in a dramatic drop to the other side of the line, and actually takes them much longer to recover. And actually, when they do recover, they haven't gone back to the same level that they were before. I would also say that frailty does not equal age. Again, when we're talking about the proportion of people that are, you know, are living with frailty, 50% of 85s, but actually the other 50% are not. And I've just put two of my heroes. So we've got Mr. Singh. Mr. Singh is the eldest marathon runner. He was still running marathons age 100. Which it makes me feel a bit bad about myself, but never mind. And then we've got Ernestine Shepherd, and she was the world's oldest bodybuilder, and she's 80, and she's 80 there with a six-pack. So don't always think that their age tells you about what their prognosis is like. So this is, again, kind of in a nutshell what we know about frailty. So it's a progressive long-term condition. It's got these episodic deteriorations. And sometimes I try and tell the juniors it's a little bit like COPD. You know, they've come in with a fall, you know, maybe they've got a worsening of their knee arthritis. They're suddenly much more dependent on people. Their function has changed. But actually, if you give them the right care, then they can have the ability to improve again. It has a massive impact on their quality of life. It's a predictor of adverse outcomes, highly expensive because they're the highest service users. We can grade it into mild, moderate, and severe, and we'll come into that in a bit more. But actually, you know, as I said, it's preventable, and actually you can do things to reverse it. This is quite a common trajectory of frailty. We see it quite a lot in hospital. So, you know, again, similar to the graph that we saw before, they're kind of coming along up here quite nicely. Something hits them. So this person's had a hip fracture, they go down, it takes them a while to come back up again, and they haven't quite reached where they were before. And it continues kind of on until that goes right down until the end. I'm a bit limited for time, so I'm not going to talk about that one. So we started thinking about frailty properly kind of at the beginning of 2000. So 2001, both Freed and Rockwood came up with their own slightly different frailty models. So Freed came up with what we call a frailty phenotype. So it's kind of, what you can, something physical that you can kind of measure and look at. And I'll come on to in the next slide about what those 3 of the 5 things are for you to be diagnosed as frail. It tends to be a much more useful frailty model when we're doing research. It doesn't tend to be quite so easy to apply to clinical work. And then the one that really has taken over much more is the cumulative deficit model. So these are things like the electronic frailty index, but also the Rockwood. I would just say that the Rockwood, when he developed it, Professor Rockwood, it was actually meant to be that you did a comprehensive geriatric assessment and then you had your Rockwood actually at the end. It was kind of the final thing that you did as part of your assessment. That isn't how we use it anymore. We tend to use it as a really quick screening tool at the front door, but it seems to be still a relatively good marker of someone's level of frailty. It also isn't just physical, it's much more about function rather than just what you can do physically. So this is Freed's frailty phenotype. You have to have 3 of the 5 for you to be considered frail. So it's weight loss with a set kind of kilograms weight that you have to lose, exhaustion, weak grip strength, slow walking speed, and low physical activity. This is the Rockwood, and I'm not sure if you're going to be able to see it if you're on a small screen, but it's going from 1 to 9, kind of progressing from 1 very fit to, well, 8 very severely frail, and 9 is terminally ill. Actually, you don't have to be frail to have a 9. I wanted to talk a little bit about electronic frailty index because it's an area that they've done some study on, and it's one of the cumulative deficit models that we use. So I believe that in the GP contract, there was a requirement for all patients aged 65 and over for them to try and be identified who might be living with moderate or severe frailty. So I think they didn't say that you had to use the electronic frailty index, but because it runs through system 1, a lot of GP practices used it. And I believe the contract asked for them, for the patients who are living with moderate to severe frailty, to have a medicines review, a falls risk assessment, and a summary care record. But it's based on, it's been well validated, 900,000 patients using lots of different read codes. And again, like I said, it's a cumulative deficit model. There's 36 deficits, and the more you have, the higher your level of frailty. So it's divided into fit, mildly frail, moderately frail, and severely frail. These are the deficits that they measure. A couple of things that I would say about it is that they're all equally weighted. So your foot problems are weighted the same as having ischemic heart disease, and visual impairment is the same as having peripheral vascular disease. Again, realizing that if you have visual impairment and foot problems, actually that makes your level of frailty much higher. It's not just looking at the medical problems that you may have. So how do we recognize frailty? So we either go looking for it, so we case find using maybe the electronic frailty index, or that older patients are presenting in crisis. And we talk very much about frailty syndromes, and it's what we screen for in hospital. So the frailty syndromes, if you have an old-fashioned geriatrician, you might still get them talking about geriatric giants, but we don't call them geriatric giants anymore. We call them a frailty syndrome. So our frailty service was set up for anybody over the age of 65 to coming into hospital to be screened for a frailty syndrome, and then for a decision about whether that made them frail. So just because you have falls, if you think, you've still got a working age person at 65 that maybe fell on the ski slopes and broke their leg, that doesn't make them frail. But the presence of a frailty syndrome means that you need to have a look to see if that does mean that they are frail. So it's falls, immobility, delirium, incontinence, and susceptibility to side effects of medication. So we've case found, or someone's presented in crisis. What can we do? A lot of the evidence at the moment is looking at sarcopenia, and sarcopenia is a loss of muscle mass and function, and it really is quite a vicious cycle. So if you've got less muscle mass, you walk up that hill, you think, gosh, that really was hard work. I'm not sure I'm going to do that again. So you do less of the physical activities, which then leads to a lower muscle mass. So there's been lots of kind of work to see how you break this cycle of sarcopenia. And this is not intending to body shame Arnold Schwarzenegger. That isn't the intention, but just to show if sarcopenia is coming for Arnie, then sarcopenia is coming for all of us. This is a cross-sectional imaging of somebody's thigh when they're 21 as the top image. You can see lots of muscle, not very much fat. And this is a 63-year-old. So again, if you were doing an MRI of a 90-something, I think the changes would be even more obvious. So it's been replaced by lots of fat, and you can see the muscle really has wasted quite a lot. So what do we do? So the real kind of gold standard key kind of intervention that we do is a comprehensive geriatric assessment. And this is a holistic, multi-dimensional, interdisciplinary assessment of a patient by lots of different specialists. And the evidence for CGAs is actually really good. So if you've had a CGA in hospital, we know that people are more likely to go home compared to kind of normal care, and it reduces their mortality. So there was a Cochrane review not too long ago showing that those who had a CGA on the ward had a 30% higher chance of being alive and being in their own homes at 6 months. But it's lengthy. So the British Geriatric Society thinks that it takes up to 2.5 hours of professional time. So it's not really feasible for everybody with frailty from mild onwards to have a complete geriatric assessment. I think we need to kind of pick our patients quite closely, sorry. So I put consider referral to geriatric medicine, do a medication review, which again is what's in the GP contract, using the stop-start criteria, thinking about really specific medications that may not be benefiting our patients anymore. And then do a care and a support plan. So, you know, the British Geriatric Society doesn't really talk about advanced care planning as much as I think they should, but I think, you know, if you're doing a care and support plan, that really does need to be about, you know, what would you want us to do in the future if things were to get worse and you weren't so well. I'm sorry, I'm going to have to click through these all. This is annoying for you. Apologies. So there's lots of different kind of preventable components that we look at. And when I look at these components, I think about a gentleman I saw in our rapid access clinic a couple of years ago, and you can see how they're all really interlaced. So his primary predominant problem was that he was lonely. He was isolated and he was lonely, which meant that he became depressed, which meant that he turned to alcohol to try and manage his mood. It meant that he stopped eating and drinking, and he had horrible kind of nutritional deficiencies when he came to see us. He became very sarcopenic, so he lost a lot of muscle mass, and he started falling over. And, you know, yes, we addressed all the other things, but what we really chose to focus on was his social isolation and his loneliness. And when we saw him, you know, a few weeks later, he was a completely different man, and his frailty scores would have changed fairly dramatically. And then I've added my own one. So, you know, I think we absolutely should be looking at continence, as well as kind of home environment and people's feet. So this was the aspiration in 2014, and I think we are kind of moving towards there. I don't think we're there yet. So, you know, the model of today is you know, your adjective, the label, the frail elderly, whereas what we want to be doing is it's seen as a long-term condition, and we're not labeling the person, that we're saying they're living with frailty. The today is that they present late and in crisis, and the tomorrow is that really proactive about giving people kind of personalized care plans. And I think, you know, I'm part of the care home support team, and we have an excellent care home support team which are incredibly proactive about managing our patients in the care homes. And the today is the hospital-based kind of disjointed, disruptive care versus the community-based patient-centered care. Again, another graph that I just like to look at, reminding myself that actually it's really hard as you have multiple kind of competing comorbidities. So, you know, down this end, kind of where the X and the Y meet, is the 65-year-old who is not frail, who has heart failure, and you follow everything to the T because it's really easy. You give them an ACE inhibitor, a beta blocker, you add in some spironolactone if you need to. Then actually you go all the way down here, and you find things starting, to compete with each other. So you've got heart failure, which is meaning that your renal failure is getting worse, which means that your blood pressure is getting worse, iatrogenically, because we're trying to help, which means that you then fall over and you break your hip. So it becomes much more about managing people's symptoms and supporting them rather than following guideline medicine. I feel a bit bad about putting this this kind of comedy thing up, but I've put it down anyway. And I think it's just thinking that actually as geriatricians and the same way as GPs, we are not organ specific. We look at the whole patient. It's a nice holistic review, and it actually gives us a really good view of declining trajectory and transition towards end of life care. So, you know, this is a lady who can't walk. You've got cardiologists coming around saying, well, she's got a crap heart, ejection fraction is 30%. We're not going to do anything about that. You've got a neurologist saying her MMSE is 12, very out of date. We'd be doing a mini ACE now. You want to do a DAT scan. The intensive care doctor saying, no way, Jose. And the geriatrician saying, actually, you know, I've had a good look at her. She's got really overgrown toenails. If we just cut her nails, she'll be able to walk. Okay, so I'm hoping that you can already see, and I'm already at 1:29, so I'm going to try and speed up a bit, but you can already see about why there is such a big overlap between frailty and palliative care. It's a long-term condition. It's got a downward trajectory. So I'm going to touch briefly on, you know, why is it important that we work together, and a little bit about prognostic indicators. So I'm not going to labour this point too much. Everyone knows, I suspect, about the Scottish study, a landmark study within palliative care and elderly medicine. Really simple idea. You follow up everybody who was in hospital on a certain day in the next 12 months. The reason I'm bringing it in is because I did the same audit, but in Hillingdon. And you would have thought I'd fix the numbers looking at how closely we mirrored the results in Scotland. So when I did it on a single day, there were 394 adult inpatients. 118 of them have died in the next 12 months. So again, 28.8% in Scotland, 29.9% in Hillingdon. When we split it into age, 44.6 over 85 had died in Scotland, and we were 46% in Hillingdon. This again, like this is my audit in Hillingdon. It really does show a really rapid kind of ramp up of people in the last year of life if they're over 85. It'd be really interesting, I think, to go back and do the study again, looking at clinical frailty scores and see if there's a better correlation with frailty scores than just with age. I went through a little bit of a period of thinking, you know, we've got lots of different tools to try and help us, you know, make decisions about anticoagulation in AF. You know, is there not one for, you know, people who are dying? Is there, you know, you put some stuff into a screen and it comes out with a number at the end, but actually that turns out to be quite tricky actually. But this is why we want to do it, because again, it helps decision making both for the professionals but also the patients and their carers. Again, the same thing for frailty as it is for kind of palliative care. If you don't know that someone's about to die, you're probably going to do stuff that's not in their best interests. I like this because I think if Niels Bohr, a kind of a Nobel Prize winning physicist, thinks that prediction is very difficult, especially about the future, then I think we're all going to find it tricky. But I did want to kind of talk to you a little bit about some of the work that's been done. So we talked about electronic frailty index, and they've mapped what happens if you're fit, mildly frail, moderately frail, severely frail. And you can see there's actually a really good correlation between if you're severely frail, about high 30s are alive in 5 years, versus if you're fit, and that goes up to about 80-something%. So there is a correlation, but it is a population risk stratification tool. And whether that's good for individuals, probably not actually, because I found this study looking at electronic frailty index, and they were trying to see if it could predict mortality. So again, really big study. It was 13,000 individuals aged over 75 who died between January 15 and January 16, and they matched them to kind of the people who didn't die. And they actually found that was a really low predictive value. So, you know, it's good as a population level, but actually for individuals, it's probably not that good. I wonder whether, you know, with COVID, the clinical frailty scoring systems and the Rockwoods really have kind of been brought to the fore, and I think there'll be a lot of study now based on these. It's not as easy to do studies on. The electronic frailty index runs through system 1. You can do lots of large studies, you know, relatively easily. whereas with the clinical frailty score, you actually need to see the patient to mark them. But this was some data that suggested, well, was looking at length of stay, readmission rate, and inpatient mortality kind of divided by your frailty score. And you can see that there are really big changes versus, you know, your Rockwoods of 1, which have only got a 4-day length of stay compared to a 13-day length of stay as a Rockwood 7. Your readmission is 4% versus 15%. Your inpatient mortality, and you know, this is quite staggering, 2% as a 1, up to 24%. And this is just inpatient mortality. This isn't long-term data. This is they died on the hospital admission. And the thinking that, you know, if you're a 7, 8, or 9, you really think about symptom control, palliative versus restorative medicine. They have put geriatric, something I disagree slightly with, is they have put geriatric medicine for 7s, 8s, and 9s, and general internal medicine for the rest of them. Again, that's not what we do here with our frailty service. We want to try and prevent people getting to 7s, 8s, and 9s. It used to be that we saw everybody with a 5 and a frailty syndrome, which means 5 is mildly frail. We have just changed that to 4 plus a frailty syndrome. So 4 is vulnerable. So if they're vulnerable and they've come in with a 4, we absolutely want to be seeing them to try and stop them progressing. I'm going to whiz through because I'm running out of time, but this shows you very similar things. So again, kind of coming back to the prognostic tools, there are some different prognostic tools, and I looked when I was a bit younger at, you know, what are there for kind of the elderly and nursing home residents. This kind of study did a lot of the work for me. So they looked at lots of different indices for different kind of patient populations. The C statistic, don't ask me what it is, but if it's more than 0.9, it indicates excellent discrimination. And if I tell you that the CHADS-FASC is 0.68 to 0.72, not great. Actually, Flacker-Keeley and MMRIR came pretty close to it in terms of good discrimination. So Flacker-Keeley worked with nursing home residents. But what's interesting about this is that a lot of the work comes out of the USA. So the USA have a minimum data set. So every new nursing home resident has this minimum data set completed for them. And they used it for kind of 100,000 patients and looked at what indices suggested that they were going to die within a few months. But actually none of them were prospectively tested. So actually this article said that we couldn't really recommend any of them. But again, what I thought was really interesting, and you know what the gold standards framework tell us is actually rely a lot on your intuition, which almost is slightly counterintuitive in the world of medicine, where it's all about science and evidence. But it does seem to be quite a good predictor. So part of the MDS, this minimum data set, was the resident has 6 or fewer months to live. And if that box was ticked, actually 50% of patients had died in a month, and 83% of patients had died at 6 months, compared to patients where that wasn't ticked. Only 5% of patients who that wasn't ticked for had died in a month, and only 15% versus 83% had died in 6 months. So this is the gold standards framework. I'm not going to tell you too much about this because I know you all know about this already, but it really is this, you know, try and think about their needs rather than really focusing on their prognostication. Again, just because I think it's interesting, and Jean Potter did a really good audit a while ago on the surprise question. So one of the things is, would you be surprised if the patient were to die in the next few months? And I'm going to come back to that in a second. General indicators of decline and specific clinical indicators. Really briefly going to talk to you about this, and the only reason I wanted to bring this up, because I'm sure everyone's seen this slide before, is the green one at the bottom is the frailty, the comorbidity, and the dementia. If you think about the slides that I've shown you before, it's, you know, they're much more kind of up and down spikes, I think, than there are here. This would predict that actually it's really easy to spot people who are end of life and living with frailty. I would say that's not always the case. And like I said, I talked to my juniors about it being a bit more like COPD, and I suspect if it was mapped, it would be a little bit more in between here. So slightly less big leaps, but keeping on going down until the end. I'm going to skip through those. So in the last, I've only got 3 more minutes left. In the last 3 minutes, I'm just going to talk about Jean's rather interesting audit that she did a while ago. And she came to the care of the elderly MDT. She came to my MDT. And it was a really brief kind of question. Do you think this patient, would you be surprised if this patient died in the next 6 to 12 months. You know, a lot of people, we said, no, I wouldn't be surprised. But then she asked the reverse question, would you be surprised if this patient was still alive in 6 months? And again, it quite a quick answer. We didn't really kind of think about it too long. It was just, okay, Mr. So-and-so, okay, Mrs. So-and-so. But actually the results were quite interesting. So once we had given her the information, she went and looked at the case notes. So looked at the notes for all the patients that we looked at and kind of tried to correlate it with the prognostic indicator guidance and the complexity. And she kind of came up with this. So she looked at 57 patients. We thought we wouldn't be surprised if 40 out of our 57 patients died in the next 12 months, but we would be surprised if 18 were still alive at 6 months. So it's quite a specific test. So we were right kind of 88% of the time, but it wasn't very sensitive, so we missed quite a few people. I wonder if Jean had carried it on a bit longer to 12 months, whether that would have actually become even higher. So, you know, again, it's this maybe slightly more intuitive thinking, and again, I don't know if it's because we can see their trajectory a bit more than an electronic frailty index that only has one kind of snapshot, whether, you know, there's other things that we're just not picking up on in our guidance. And I think I'm going to stop talking. So this is the summary slide for the end. It's common, risks, adverse outcomes. You should go and look for it, and once you found it, we should do a comprehensive assessment. And frailty is a predictor of many things, including death. So advanced care planning is the key.